All my life, God has been faithful indeed. He has been good to you, to me, to us, and we are also very grateful. Welcome to our Medical Monday. Um, I know Dr. Dunnigan was in transit, so I'm not sure if he was able to get back on. But we are going to open in prayer, and if he's on, we're going to turn it over to him. And if not, then we'll ask Dr. Coker to introduce our speaker for tonight. All
Sure.
right. So let's pray and get started. Our Father and our God, we are so grateful to you for the privilege, the opportunity to gather together once more as your children. We thank you, God, for this time, this Medical Monday that has been organized to inform us of our health, that we may be able to take care of these bodies, your temple. Bless us now in this our time together. We ask your special blessing upon our speaker for tonight. Give her all that she is in need of to impart the knowledge that she has to us. We give you praise, honor, and glory in advance, and we pray it all in the name of Jesus with thanksgiving. Amen and amen.
Amen. Thank you so much, Dr. Dennery. All right. It is my pleasure to introduce tonight's speaker, Dr. Carol Guy. She is an advocate. She is a mentor. She is a mother. She is a grandmother. She is a wife, and she loves her family. She was raised in Philadelphia. Go Birds! And she went on to Howard University in Washington, D.C. And then she returned to Philadelphia, where she graduated from Temple University School of Medicine in 1988. She went on to complete a pulmonary and critical care fellowship at Hahnemann University and later did a sleep fellowship and training in clinical epidemiology at the University of Pennsylvania. She is an advocate for Black providers in America's healthcare system, and she serves as the chair of the American College of Chest Physicians Diversity Network, where she develops a mentoring program for others. Somebody has got two speakers on. Who is that? All right, so we'll take that off. She is presently the chair of Region 2 for the National Medical Association. She served as the Region 2 vice chair from 22 to 24. She is the conference program committee chair. She is the political action chair. She is busy. During the pandemic, Dr. Guy joined us as panelists. She joined us in vaccination. She wrote tons of op-eds to make sure that people of color got ventilators when necessary, that they got the proper health care needed. And we are grateful to Dr. Carol Guy for her service, outstanding service to our community. So without further ado, I would like to introduce to you Dr. Carol Guy. Welcome, Dr. Guy.
Thank you. I'm honored to be here tonight. Thank you for this invitation, Dr. Coker. That's wonderful. And it was such a pleasure working with you to serve our community during that pandemic. So some of you I'm new to, some of you I know for many years, having the honor, having served you and taking care of some of your pulmonary needs in our community. And Dr. Dunnigan, if you're on the call yet, greetings to you, sir. I bring greetings from my church home, Bethel AME, with our pastor, who is the Reverend Dr. Stanley Hurst. So tonight we're going to talk about three things Dr. Coker asked me to be brief on. We're going to talk about COPD, chronic obstructive pulmonary disease, asthma, and pulmonary embolism. I have one thing to please correct. I talk fast, like extremely fast. So if I'm going fast, raise your hand, shout out, whatever you want to do. Tell me, slow down, Dr. God, that's too fast. So when I get excited and passionate, tell me slow down, and that's what I will do. I like this to be interactive. I'm going to give some information after each top. I think it's a lot to get through. We can kind of ad lib, however it goes out. I'm so excited to see so many folks on this Medical Monday. This is a wonderful ministry that you have, and congratulations. So without further ado, I'm going to get started here. Let's put that over here. Let's see. Okay. So our bodies are temples. Our bodies are our temples. You know, our bodies are the temples of the Holy Spirit. So we already gave this. I'm a retired health advocate We're going to first start with the pulmonary conditions are chronic obstructive pulmonary disease, which also is emphysema, asthma, and we're going to talk about blood clots, whether they be in the lung, pulmonary embolism is the medical term, or deep venous thrombosis, where most of them come from the legs. So I could not come here and say a little bit about tobacco-related injury, just to talk about, we all know about smoking, but the new thing, or not so new, is vaping-related lung injury. Right before the pandemic, this was in the news, but it got out of the news, which is good, because the actual severity of this illness, we calmed that down. But still, we have a long way to go. Lots of folks are vaping. Our young folks are vaping. It's unfortunate we have a whole new generation of folks who are hooked on tobacco, nicotine, due to these electronic cigarettes. So vaping-related lung injury actually can cause serious respiratory conditions by inhaling these vapors produced from electronic cigarettes, which we call e-cigarettes or vaping devices. There are chemical substances in them. There's nicotine, some other things, diacetyl, vitamin E, acetate, heavy metals. This vaping-related injury can be serious and life-threatening. It causes shortness of breath, chest pain, nausea, vomiting, diarrhea, fever, fatigue, and it increases folks' risk to go on and develop chronic obstructive pulmonary disease. Despite, this is really important, so I said I would be remiss if I didn't bring this up. Despite e-cigarettes' ability to achieve tobacco cessation, based on available evidence and lack of our knowledge about our long-term effects of e-cigarettes on our respiratory, our lung systems, we cannot recommend for smoking cessation at this point in time. So we're going to go ahead and get started with COPD. So what is COPD? So COPD it stands for chronic obstructive pulmonary disease, emphysema. A lot of folks who have COPD, for practical purposes, have emphysema. Emphysema is lung destruction. Some folks have more of the chronic bronchitis type, where they have a lot of cough. But emphysema is when the lung tissue has been destroyed. So folks can present with a lot of different symptoms. They can be short of breath. If you have COPD, you can look in your portal and chart. When you're looking at, I gave this term dyspnea, because now everybody should be able to look into their chart, whether you go to Christiana, St. Francis, or any other hospital, whether you go to hospitals in Philadelphia, anywhere, you should be able to ask your healthcare providers to have access to your patient portal. When you get into your patient portal, they were designed for physicians talking to other physicians. That goal is changing a bit, but we're slow to catch up. So there's terms in there you might not understand. So you'll see this big fancy term that says dyspnea. All it means is shortness of breath. And if there's something in your portal you don't understand, figure out who the person is you could discuss it with. You could ask your doctor, but there may be other folks too if the visit time is limited. Oh, and also a lot of stuff is you can look up online too. So there's terms in there, because it wasn't designed initially for the patient. Although, like I said, that's changing, right? Sputum, so that's your mucus production. Patients who have COPD have sputum production. Some of those who have more of what we call the emphysema type might not have that much sputum. Exacerbation, that's the other fancy term you might find in your chart. If you have COPD, that's simply a flare of your disease. So what COPD does, even after persons have stopped smoking, there's continued damage to the lung airways. So it's like the horse galloping. Smoking does improve the COPD outcome, improves mortality, like your risk of dying. But once the horse has galloped, it will still continue to gallop, just at a lower rate. So you'll hear people say, "Oh, it's no point to quit smoking because they'll know someone that had COPD. They'll say they stopped smoking and they were still sick." That is absolutely untrue. So they are still sick. That part is true, but it's very worth your while to quit smoking. When you quit smoking, it reduces the flares, it reduces your risk of hospitalization, it increases your chance of remaining on this earth, so it decreases what we call your mortality, your risk of death, right? And also it reduces your risk over time of lung cancer. Your risk of lung cancer never goes to the general population, but it goes down over a 15, 20-year period to be kind of close to, but never the same as. So it is very worth your while to quit smoking. So smoking, like I said, causes damage to the lung airways, the bronchial tube. So if you look at this picture, this is your trachea, your windpipe. If you touch right here, that's your windpipe. So what happens is this little thing right here in our neck called our trachea or our windpipe right here, it divides out right here. So right about here, midway down in your chest, it divides to the left side, the left lung and the right lung. And it is opposite. That's how. So the left lung and the right lung is transposed. That's correct. So on the left side, it divides out and it branches out to, we call these bronchial. We always say, your breathing tubes. So the breathing tubes are your bronchial tubes. These are your airways. And then out in this tissue of the lung, the big fancy term is called alveoli down here. So when people have a lot of emphysema, what happened to them, for whatever reason, they have destruction of this tissue out in the lung. Whereas patients who are more of the chronic bronchitis type, they have all this airway disease. And most people have a mixed bag. And if we did what we call, when patients die who've had COPD, if we did what we call pathology, we looked at what they had, we would see they both had some of each, actually, in the lab, like after the person is going on to glory, right? But in life, some people have more of chronic bronchitis symptoms. Some people have more of emphysema or lung destruction. And a lot of people have both. Okay, so let's see, next slide here. So I like these new signs because they're both saying no smoking and no vaping. So, and they put it on the airplanes now too about no vaping. And I've been in places and spaces before. I'm like, okay, we need a no vaping sign. Now they do have no vaping signs now, which is great. And that's a whole nother talk, but our children could be vaping. It's very regional and geographic. That's a separate talk worth the while in the church ministry, because children could be vaping and we didn't even know it, which is big. So we're a decade behind in vaping, which is unfortunate. And actually, unfortunate is that folks who knew better started vaping and now they're addicted because it's addicting. And some vapes that say no nicotine do have nicotine. The good news is Delaware has been very good. The American Lung Association have been very much on top of this. In our state is one of the few states that actually spending some of this money on this vaping, get rid of vaping initiative. So that's good news. But we need to that's a separate talk, but we need to be at that table to make sure our children and our communities are actually educated too about not vaping. That's another day for another discussion. But anyway, COPD, chronic obstructive pulmonary disease, the risk factors. First of all, people go, why are we talking about COPD? Well, it's the third leading cause of death worldwide, all over the world. And more women have COPD because going back, women started smoking probably like around in the 70s or so, or 70s. And so then that's why their risk increased and went up. So the most common reason for COPD is environmental exposure, tobacco smoking and inhalation, but also toxic particles, gases from the outdoor air, pollution. Some persons have COPD, they've never smoked in their life. They had passive tobacco exposure, and they also could have had an occupational exposure. And also some folks who have abnormal lung development and also have accelerated lung aging. As we see more premature patients, and this is as patients, we save some infants from their prematurity. They've lived long. Not most premature infants, but those who are extremely premature. I've had some of my patients in my practice who actually grew to be in their 20s now. They actually have COPD. Some of those persons have COPD. But the good news is we save those infants. As we get better and better, hopefully they won't have it. But they do. Some of them who have had severe prematurity, not just this mild prematurity, do go on to have COPD. So this is the fascinating things. What we're learning about all diseases, not just, so in all diseases, we're learning something new, which is pretty cool. Most diseases have both. It's not just the environment, it's also genes. So you also hear people who would say, I'm going to smoke because I had my uncle smoke today, or I knew a person that smoked till they were 100 years old and nothing happened to them. And that could be true. Because the reason is there's a genetic and environmental interaction for all diseases, including in COPD. So that's why your family history is important. So what I tell folks is real important. So if you have a family history of COPD in your family, it's good to tell young folks who are in those families that your chance and that persons in those families have COPD, it's quite likely that the persons who are young, if they take up this habit of smoking or vaping, might go on to get COPD. So it's correct. If some folks smoke till they're 100, they're blessed. They don't have the genetics. They're just fortunate. But this gene and environmental interaction is what the trouble is. So smoking clearly causes it. It's just some people don't have the genetic, that risk factor, they're not going to have COPD. Then there's a rare genetic mutation on every person who has COPD. If you have COPD, make sure your doctor check you for this rare genetic mutation we call alpha-1 antitrypsin deficiency. It's rare, but if persons have it, it causes advanced COPD. They get it at a younger age. It's a more rapid decline, and we have medication. It's very rare, but we do have medication to assist them with that decline in their lung function. So how do we diagnose? How do you know you have COPD? If you're concerned. So the doctor's going to take a history of your symptoms. They're going to do a physical exam. There's many what we call severity questionnaires to determine how severe your degree of chronic obstructive pulmonary disease or COPD is. Then the doctor's going to do this little test right here, the breathing test. You're going to blow into the machine. We have spirometry right in the doctor's offices now. So your primary doctor may have the spirometry, but like Dr. Coker, myself, I don't practice, I've closed my practice, but Dr. Coker would have this in her office too, to do your spirometry right there in the office. You can look at what your lung function tests are, okay? We do more sophisticated testing in office settings, or if if there's no access to the office setting, then you go to the hospital where we have a pulmonary function lab. They also we all learned about pulse oximetry during the pandemic, and oxygen saturation also. Then, and this one, because we're all this community, we're changing this, how this looks for us, because the pulse oximeters were not calibrated to correctly diagnose oxygenation in folks who are pigmented like us. So that is being changed. The pandemic, that's the good outcome of it. We're changing that. So some folks, unfortunately, when we have articles and we have data, which was very sad. And unfortunately, one of the disparities when the COVID pandemic was that some folks of color went home because we thought their oxygen saturations were higher than they actually were. So they should not have been discharged because those machines were not calibrated, just like, for example, so that's something that killed folks. Like the new iPhones now calibrate for our skin color, right? Because that's new too. That's superficial, right? Because how you looked in the picture, this was not superficial. We had loss of life because of this, but it's being recalibrated and they're changing these machines as we speak. So that was the good outcome that we're going to do something about it. And we learned that during the pandemic. All right. Arterial blood gases, that's when, in your doctor's office, they can do this in the office. You could have these, you could buy these over the counter now. Since the pandemic, you could buy them right over the counter. I have pros and cons about getting them, but that talk to your doctor about that part. Now, arterial blood gases, that has to be done in the pulmonary function lab. It's not done in your doctor's office. They'll send you if you have COPD, they're going to send you to the pulmonary function lab. Here in Delaware, we're going to send you to either Wilmington Hospital or the Christiana Hospital. That's where we're going to send you. You're going to go to the pulmonary function lab. The respiratory therapist is going to put a needle in your right above, it's called the antecubital area in front of your elbow, or right there in your wrist, and they're going to stick it, and it does hurt. I tell them it hurts, so it hurts, but it only hurts for a second. Well, maybe it hurts for 2 seconds, 3 seconds, because it does hurt. I'm honest with my patients so they know what to expect, but you have to have it done because we can't measure your oxygen. We can measure your oxygen off the arterial blood gas, but we want one accurate assessment of your oxygen, and two, there's something called your CO2. We want to know in patients with COPD what their CO2 is, The doctor should do it for your first visit with the specialist, with the pulmonologist for COPD. You should have some labs ordered. It just has to do with treatment. So alpha-1 antitrypsin, any new patient with COPD should have this test for this rare genetic condition. It's very rare, but you should have at least one of them. And with the new treatments for COPD, this is new. This is brand new, and we're still figuring this out. But every patient with COPD should now also have what we call blood eosinophil count. We always used to think eosinophils is something that have to do with allergy or inflammation. Let's think of allergy and inflammation. Think of it that way. So we now know that patients with COPD has some things that looks kind of similar to asthma. We always thought that, but we have some evidence and some of the new medicines will help them. So that's the good news. We got something a little bit new to help some folks with COPD. So these are what some of the questionnaires look like. This one's called a modified MRC dyspnea. Remember I told you that term dyspnea is shortness of breath scale. So your doctor will ask you to fill this out, and they will ask you at every visit. So you tell you, I only get breathless with strenuous exercise. I get short of breath when I'm hurrying on a level or walking up a slight hill. I walk slower than people of the same age on that level because I'm breathless, or I have to stop for breath when I'm walking at my own pace. I stop for breath after about 100 meters or after a few minutes, or I am too breathless to leave the house, or I am breathless when dressing or undressing. These charts should be in these. You should have, and there's another one. It's longer. It's called a CAT scale. But these are how we help to follow how you feel, because it's kind of, it's subjective how you feel. But this kind of helps your healthcare team to better figure out how you're doing. So these questionnaires are important, and particularly sometimes when you go to the doctor, you may feel rushed sometimes. These things help us to actually take that feeling away too, because then sometimes it's gonna be filled out ahead of time too, or right while you're sitting in the waiting room. We're getting there. Don't go to your doctor and say they didn't have this yet, but we're getting there to try to make it's a work in progress, because it's a big work in process, how to figure out how to integrate the computer with taking good care of you. Because the old-fashioned way was the paper and pencil, sit down and I have an hour to talk to you. That has changed, and we don't like it. Neither does the patient. Nobody likes it, but it's not going to go away. But we're trying to figure out how to make it a good experience for you. So these are some of the ways to do it too, is to have some of this question outside of that room so we can spend time talking to you and figuring out how we can help you. Okay. So a chest x-ray, it's not necessary to make the diagnosis of COPD at all, but you will probably have a baseline chest x-ray. And then oftentimes patients with COPD will end up with a lot of chest x-rays, because sometimes we're trying to figure out, do you have a bronchitis, Or do you have pneumonia when you get a flare? Just as simple, not simple, an exacerbation. So pneumonia, bronchitis can be just as severe, but sometimes the treatment could be different. And what we're going to do about it could be different. So you're going to persons who have COPD may end up with a lot of chest X-ray, at least one an annual chest X-ray. So typically, it doesn't have to be, but typically, if I'm a pulmonologist, I'm seeing my patients, if they're stable, I'm probably going to do an annual chest X-ray once a year. But I'm definitely going to get a baseline chest X-ray. And like I said, we're excluding a lot of other things, and we're also looking when the patient has symptoms. What does that look like? And we want to know what your baseline looks like. So this is your heart in the center of this field right here. This is your lung here on the left side. This is your lung on the right side. These are called this is your breathing muscles, your diaphragms right here. This is your trachea, your windpipe, and this is where it divides off right here to your left side of your lung and your right side of your lung.
Dr. Guy, could you slow down a little bit, please?
I'm sorry. Yes, I will. Thank you. I'm glad you told me. You should have told me before, but you're right. Thank you so much. Okay. So, all right. So this is let me see what this picture has. Hold on for 1 second. Okay, so this is a CAT scan in COPD. And the reason I'm showing it, because now we can look in our charts now, we can look in our patient portals, and it could be very confusing. So it's good and bad. The good part, you can see everything that's going on, so you could be an active participant in your health care. But it can also be overwhelming sometimes. You're like, what is this? What is this in my chart? And you can have the information before your doctor has it, which sometimes can be confusing too. And those are things too we're working on. So even like, Medicare does a lot of work on this, and it actually helps people who aren't even on Medicare yet, because what happens is then the other insurances start requiring it too. And then too, it helps with the electronic health record looks like, and some of it then gets standardized so that it can help patients. So that's how that works. So this so that's why I put this up here, because you may actually be able to see this yourself. You're like, what is this? So on the first slide here, this is a normal CAT scan. And you don't have to know what it looks like, but I'll just tell you it's normal. But I'm glad to show you, so you'll actually be able to see it, so you don't have to get overwhelmed, because you'll be able to see what I'm getting ready to show you. So if you look real hard on this one, then let your eyes go over here. If your eyes go over here, you go to some black holes over there. I'm gonna show you the black. These are the black holes where I'm putting my pointer. Can you see my pointer? Can you see the pointer? Somebody tell me they can see these holes I'm pointing at. Can anybody see these holes? Somebody tell me who's in the audience. Yes or no?
We can. Mm-hmm.
Yeah, so it's not that hard, right? So it really is. So you could really, so the radiologist will read that, the pulmonologist will read the CAT scan too. And the CAT scan will help them determine the degree of actually emphysema, which is lung destruction. They can tell some fine things too about chronic bronchitis, like there's sometimes mucus impaction, there's different things that happen, how the airways look. The airways are these little circles. This is normal. These airways right here are normal. Like this is an airway right here. So that's normal. This hole is supposed to be here, which I'm showing you. But these holes out here are not normal. They are lung destruction. So that's why the doctor may, depending on what your symptoms are, they may order a baseline CAT scan. If you have symptoms or problems, they may order a CAT scan to figure out what is going on. But so that's what the CAT scan test is going to help us with. And sometimes you'll have a report in your chart before the doctor has a chance to look at it. But you want to almost make sure you review it with your doctor. The other little plug I want to give is we're not like, and CAT scans of the lung, we're not up to point like we are in breast mammography. So what I tell all my patients is, we're getting there, but we're not there. We're nowhere near there. Delaware is better because we're a small state. So if you have had a CAT scan of your lung, whether you had it in the emergency room, if your primary doctor ordered, a person in the urgency care center ordered it, it's your duty as the patient. You have to do this. This is the new way. You have to make sure you have seen the result and you know the result is normal. So don't assume because the emergency room did not call you back, that your doctor did not call you back, that whoever ordered didn't call you back, because it could be an urgency care center, it could be a primary care doctor. Don't assume that test was normal. So no doctor ever looks at the test result and goes, oh, the patient has lung cancer. Oh, they have this pneumonia. Oh, I'm not going to tell. They never saw the report. That's what happened. So it is not like mammogram. It's the model mammogram system took decades to get like that. It took hundreds of millions of dollars to get like that. This is a work in progress. Delaware is ahead of the other states because we're small. So we have something called DIN, which we started maybe 20 years ago, about 20 years ago now, Joe, I think about 20 years ago, where, and I remember when it started, and what happens if the doctor signs up for DIN, it will jump into the doctor's chart. There was some funding for DIN to start doctors out with it. Now you have to pay for DIN. But I think most doctors may have DIN, but they may not. So they might not always see the result. So they might not know. So when you don't make an assumption, and don't ever assume it's in my chart, and make sure that you know what that result was. Don't assume like that that they got the result, because they never had it. They're not going to ignore a bad result. They never had the result. That's very important, extremely important. Okay, so next, go to the next slide here. Oops, go backwards. Okay, so the healthcare team, when you have COPD, this is very important too, because you have to be an advocate for your health. The way we practice medicine has changed. So my dad was a physician. It was very paternalistic. So in my career, it started out that way. It moved somewhere, it moved and it moved and it moved. So there's pros and cons both ways. But now we're what we call the patient. It's the patient and doctor. It's the healthcare team and the patient. So you have to be an advocate for your healthcare at this point in time. So you have to really advocate. I think we're a little too far over here, but it's okay. But that's where we are, and I don't know where we're going to go. But I think, so you have to really be a big advocate for your healthcare. All right, so. Your healthcare team, if you have COPD, should consist of your primary team, which is your primary provider. It could be your doctor, your nurse practitioner, the physician assistant, or all those persons. The pulmonologist, the lung doctor, the pulmonaries in Delaware in Delaware now. We do use a nurse practitioner, a physician assistant, and this is where I want to talk about advocacy for your health. That is fine, but I want to make sure if you have COPD and if it's not your initial visit, you need to insist, and really should be, in my opinion, your initial visit, if you have COPD, should be with the pulmonary doctor, period. That might not be the case, and I don't agree with it, but if it's not the case, you need to advocate that the next visit, if the first time you have COPD, is with the pulmonologist, okay, period. Now, subsequent visits, I'm actually okay with. If the person's stable, I'm actually okay with I have trained physician's assistant actually to do. When we first got physician's assistant in intensive care at Christiana, I was one of the first folks to train what that looks like in the ICU. So it's a good space for many providers, but I am a staunch believer that if you need to see the pulmonologist and it's your first visit or your second visit, you need to have to see the pulmonologist, period. Yep. So you need to advocate for that to occur. If that's not what happened, you need to say, you need to advocate that occurs for you. Respiratory therapist may be part of your team. Pulmonary rehabilitation, when indicated, is part of your healthcare team. So let me just do this. So how do we treat COPD? So you'll see my first sign, the most important thing is if the person smokes, to quit smoking. So we're going to quit smoking. There is nicotine replacement, pharmacotherapy to quit. Delaware has a tobacco quit line, which it varies on the funding. If they had the funding, and it'll help pay for your nicotine replacement, and that can change. It changes. It goes back and forth. And then the second thing, we screen for lung cancer. I'm going to show you who in a second. Vaccines are extremely important. So we see this gentleman vaccinating the patient. The doctor's vaccinating the patient right here. So the influenza vaccine we need when we have COPD, pneumococcal vaccine, DTaP is important because of pertussis, mainly a whooping cough, which can be extremely problematic. Shingles, RSV if you're over 60 and have COPD, and COVID-19. Okay, so lifestyle is very important too. So you see my set of weights here. Nutrition, safe exercise is recommended by your healthcare team. I had a patient that had advanced COPD, and he reminded me, and he lived to be he was fortunate and blessed. He had longevity. I probably took care of him for maybe 25 years. So it reminds me of one of his more later visits later. Dr. Guy, did you know I'm 80? Somebody said, oh, yeah. He said, that I'm still using that treadmill, like you said. I got my oxygen. I said, oh, yeah, that's good. He had his oxygen for 20 years. I said, that's why. He said, now I'm going to do one last travel. So that actually makes quality of life is extremely important, not just quantity. So patients with COPD, even advanced disease, could actually have a good quality of life. And that part of that is this lifestyle nutrition. So a lot of folks, I am an advocate that everybody should have pulmonary rehab. We have been a stepchild in pulmonary for pulmonary rehab payment, which is awful. Cardiac gets more payment, but I've even been to Congress to advocate about that. Like, we are the stepchild. This is not good. Okay, everybody needs to get reimbursement for pulmonary rehab. That is not the case. It's unfortunate. We have outcomes data too that shows if patients have been hospitalized with COPD, they get pulmonary rehab right after. It keeps them out the hospital. But besides that, I think every patient with COPD should be able to get pulmonary rehab. That's not the case. They won't pay for it, but they should. So I'm gonna keep on advocating till I can. Okay. All right. Oxygen, when indicated, it's not indicated in all cases. Your doctor will discuss with you, but it should be tested for and see if it's indicated at all. Non-invasive ventilation was people. You guys know about CPAPs and BiPAPs. I'm sure somebody in the family or uses it themselves that has a CPAP or BiPAP machine. Sometimes we use these machines or cousins of those machines to help people that have COPD. and it could be really change the quality of life. That isn't only an advanced disease, but it could be life-saving, but also change quality of life. And then sometimes for patients that's not going to work. There can be, for certain indications who have advanced disease, there's bronchoscopic, what we call bronchial valves, or surgical intervention when indicated. Christiana, we're fortunate to be in an area where they actually have two interventional pulmonologists, which is great. Interventional pulmonology used not to be a specialty; it's a boarded specialty now. Came across during my time of practicing, but we actually have two very good interventional pulmonologists in Delaware. There's good interventional pulmonologists in Philadelphia. Should you need any of those things. Lung transplant has not turned out as nicely as we like, but that is an indication. We like to do these other things first. I didn't even put it on the slide, but that is a lung transplant. It can be used in advanced disease. And did we say inhalers? Of course, folks know about inhalers. What we call the term is bronchodilators, because you might see that in your chart. And there's a whole bunch of different types. And you might see these terms, LAM, these are medical terms, LAMA, LABA, this little steroid part. And then what we want to do with our patients, this is where you need to advocate for yourself. This is extremely important. So all my patients that have COPD know how to self-manage. And what I mean, and we have to do coaching. So what I mean by that is you're at the education of the patient with the whole pulmonary healthcare team should be so good that they're able to know when they need to call their healthcare team. They can distinguish when they need to go to the urgency care center. They can distinguish when they need to go to the hospital. They can, in matter of fact, when my patients have good self-management and coaching, they should be out of the hospital mostly. Sometimes we can't avoid that, but oftentimes when you've done a good job, they're not in the hospital. They can have very advanced disease. So that's very important. So if you're in the hospital all the time, it may be even good self-management and coaching that's still going to happen, but that's not always the case. So that's when you need to advocate for yourself and make sure that you really understand your disease, because we have to work together. And you have to understand enough about it too that you could actually tell me. I had one patient that he take his little paper. I said, "You want me to print it out?" He said, "Nope, because I got this paper from before they had to print them out." So he took his paper everywhere to Greece, and he would carry it to Greece, come back from Greece. He said, "No, this is the paper." I said, "That paper," but he kept that paper, and he would even call from Greece. I told the pharmacist in Greece, I said, "Look at this paper," and that's what I'm supposed to have. We would go for extended periods, but that's really, really important, particularly how we're practicing medicine now. So, like I said, we went from a paternalistic approach to we're way at the opposite end. So you really have to make sure, but that you can advocate that you understand what they're talking about, and that you keep till you get it, until you're on board, so we can work together. And then that's important too. So I told my patients. So for example, when a pulmonologist is covering Delaware, you're covering all of Delaware. So luckily, I missed my patient, but I don't miss that part. So you're covering all of Delaware. So you're getting calls from. So when I'm covering, I'm cross covering. So I'm getting calls from my own patient, from about 10, 12, or 15 other pulmonologist patients. So what I educated my patients to do was this. I would write down what you're supposed to tell that doctor. Do you take steroids? What is your regimen? I had them on the paper. How often have you been in the hospital? So that's part of self-management. So guess what happens when that happens? When that doctor, who does not even know them, feels comfortable then to make a decision on the telephone. If the doctor can't hear all that and somebody has COPD, they send them to the urgency care center, period, because they can't hear any of that. They don't know what the patient, if they understand their illness, they're not comfortable, because this could be a life-threatening disease, right? So, but if the doctor, if we've had good self-management, you've advocated for yourself, you don't necessarily have to go to the urgency care center. Even if you get a doctor who's covering that doesn't know you, because they've heard the right things, that they feel comfortable, that they can tell you to do this and go to the pharmacy and get this. But if they don't hear that with this serious disease, you're going to the urgency care center, emergency room. And that could have been avoided had we done some of this self-management and coaching. And then when you get to the urgency care center and ER, they don't know you either. So then we could have avoided a hospitalization had we done this self-coaching and management. And it's bad, because sometimes when you go to the hospital if you can't. I'm not discouraging that. I'm saying that because if we don't know it, you got to go there, right? But we keep people out the hospital. They do way better over time. They live longer and have better quality of life, and they get less. They just do better. So it's really that part is extremely, extremely important. So pulmonary rehab that we talked about is really good in COPD. We need more funding for it. So anybody that works in advocacy and all those things, is it down in the in Delaware, in the Congress or anywhere, we need pulmonary rehab. So that's my big push for that. Oxygen that we talked about. Okay, so let's see, next slide. So like I said, we're going to quit smoking. And you could quit. I have patients who, so first of all, let's be clear. It's extremely hard to quit smoking. So it's actually harder. Patients who have an addiction and who have, no, because nicotine is an addiction, but who have a substance, like a substance addiction, and who also have a nicotine addiction. The nicotine addiction is usually the harder addiction to get rid of, but people do quit. I've had patients who smoked for 60 years and then they quit. What all patients told me, it's hard, but what all patients told me, they said they had decided this time. They said they had to quit. So most people take about 9 times before they quit. So don't give up on yourself. It takes a long time. May take multiple tries to quit. That's normal. So you just keep trying. Nicotine replacement does help. Pharmacotherapy does help to quit. Like I told you, we can't recommend e-cigarettes. They do help people to quit. We can't recommend them because we don't know what the long-term side effects of that inhalation product in your lung is. That's the problem. And then we have so we don't know, that data is not available. We don't know what the answer is. Okay, so we can't tell you that is what you should do. Now, for certain patients, we're going to screen for lung cancer. Okay, so when indicated with low dose CT of the chest annually. So age 50 to 80, you can get a lung cancer CAT scan if you continue to smoke. We want you to quit, but there's rumors going around that people can't get a lung cancer screen if they still smoke. That's not true, but we want you to quit. So, and also the point is, because you have an annual CAT scan of your lung, you say, I'm gonna keep going to get this, so I'm okay, I can keep smoking. That's not true. So the damage is still occurring. It keeps occurring. It's continuing to occur if you keep smoking. So we want you to quit. So if you're a current, a former smoker, or you quit within the past 15 years, or you have a 20-pack year history plus of smoking, the pack years, like if you smoked the 1 pack for 20 years, you have a 20-pack year. If you smoked a half a pack for, 20 years, you got a 10-pack year history of smoking. So there's a whole bunch of spaces on the electronic health record to figure that out. I want to give a plug there that don't underestimate your smoking, because then it could eliminate you. We're honest, but you have to, if you underestimate it, because people don't want to say I smoke, so they want to because we're human beings, right? So we want to minimize it, because we all know people that smoke know that that's a bad habit. It's an addictive habit, so they're addicted. That's why they addict children, they addict teenagers, because it's rare for somebody smart to start smoking after the age of 18. It's rare for them to start smoking after the age of 16, really. But so it's very rare. It does happen, but it's extremely rare, right? So they know that it's a bad habit. At that point, they're addicted. So then people like to underestimate it because they feel like it's something they should be able to control, but it's an addiction, right? So I tell my patients, please do not underestimate the amount you smoke. And you don't have to guess exactly, but it's about, if anything, overestimate it, because then your insurance company's not going to pay for this CAT scan. It could be life-saving. So it's really important. So we just changed, the guidelines were just changed 2 years ago to actually get more people, because we knew that, first of all, Black folks get lung cancer with less cigarette exposure and at a younger age. So we reduced, this is one of the reasons it was higher before, it was 55. And then the pack years was, all this was higher, but we knew that the Black folks were getting lung cancer at a younger age. So this new screen actually does help to put us in it, but it also still has a disparity. So despite that, there's still disparity in the screening tool when we talk about African Americans or Black folks. Okay, so that's that. So it's really important. So if you know somebody that fits that, tell them to go get their lung cancer screen, and tell them that lung cancer is not a death sentence. We have treatment. That's the other thing why some patients won't get a screen, because some folks think lung cancer is a death sentence. We have a long way to go. We've come a long way. I've had patients with advanced lung cancer now. Before I closed my practice, I had a woman who actually did not smoke. There's some unfortunate folks who never smoked. It's unfortunate if you did smoke, but some folks who never ever smoked, who are the 10% who never had passive tobacco exposure either. So they're a real small percent, maybe 5%, that happen to have lung cancer. And she had presented with metastatic lung cancer. And at the time I closed, she was 5 years out and doing well. And if you saw her, you said she doesn't have lung cancer. You look at her, you go, she can't have lung cancer. She did. Okay, so it is not always a death sentence. There are things we can do about lung cancer now. So please encourage, if it's not you, if it's someone you know, please tell them to ask their doctor about lung cancer screening. So we're going to shift gears. Are there any present questions that you can't wait till we get to the next part? Can we ask? John, you want to stop and ask about COPD, or should I keep?
There was one question in the chat that said, what is the difference between pneumonia and bronchitis?
Excellent question. So the difference between can I go back to that? I'm gonna go back to that slide and show you something. That X-ray, I'll show you something. Okay, let's do this. So this is a chest X-ray. Okay, so when you have when you get bronchitis, so this is the trachea, and then this divides out to these bronchial tubes. When you have bronchitis, you're gonna have inflammation and infection inside your bronchial tubes. Okay. When you have pneumonia, it's gonna be out in this lung tissue I told you, called, the fancy term is called the alveoli. Okay. So like right now we heard the Pope has bilateral pneumonia, right? So pneumonia, both of them could be, so people always get confused that they always make the assumption that bronchitis, so there's two types of bronchitis. First of all, there's a chronic bronchitis, which is patients with COPD have chronic bronchitis. But then there's acute infectious bronchitis, okay? So not to be confused with, so acute infectious bronchitis, which is different than chronic bronchitis. That's not an infection, okay? Although it's complicated, but let's just assume it's not an infection, okay? So, but acute infectious bronchitis, like pneumonia, they're both infectious. We could talk about infectious pneumonia. Okay, they're both infections, okay? They both can be very serious, right? Typically, we think pneumonias could be more serious. Not always the case, though. There's some viral pneumonias could be severe. Like if you get COVID pneumonia, that's bad. If you get influenza pneumonia, it's bad. Most of the time, influenza pneumonia is not what kills you. What happens is when you get viruses in your lung, whether that be COVID, influenza, RSV, what often happens, it makes your lung system weak, and it sets you up to be able to get what we call bacterial pneumonia. So pneumonia causes it, what we call infiltrate, because it's out. Remember I told you it's out in the lung tissue. It's out in these tissues. So you're gonna get something on your chest X-ray. So you can have an acute, not a chronic, acute infectious bronchitis, and your X-ray will be clear. And that's how sometimes the doctors distinguish. But both an acute infectious bronchitis and pneumonia could both give you fever, chills. Both could be reasons for hospitalization, particularly in a patient with advanced COPD. But we can sometimes treat it at home. It depends on what's going on. Diabetics are more at risk for pneumonias. If a person has, something's wrong with their immune system, they're more at risk for pneumonia. My patients who have COPD can get an acute infectious bronchitis, in which times we'll oftentimes give them antibiotics during that spell. And Dr. Coker's patients who have, chronic sinusitis, they can end up getting infectious bronchitis. It first starts out in their sinuses, then it jumps down into the bronchial tubes, then it gets down in my lungs. So that's kind of what it is. Did that help the person who asked? Is that satisfactory for that person?
Yes.
Okay, you're welcome. Okay, so let me go ahead. Any other COPD? We're going to move to asthma if not. Okay, so for asthma, it's extremely common. There's 300 million people worldwide who are living with asthma. It's a chronic long-term disease. This I want to emphasize, because some folks say they outgrow asthma. They may, and that is possible. But some folks who say they outgrew asthma, they just mean they have infrequent asthma. And what I want to teach your point is really important. They still have asthma, and you'll see as we move along why that's important. But they can live well with it. We've had Olympic athletes who have been spokespersons for the American Lung Association to say how you can live well. We've had Olympic runners who have asthma who've been spokespersons for, the American Lung Association, which is great. So asthma that looks treated can look great, and you could be an Olympic runner. All right, so but that same Olympic runner untreated could die suddenly from asthma. So asthma is a tricky disease. So some folks with long-term asthma may have infrequent symptoms. Others have frequent or severe symptoms. And so people can go through spectrums where sometimes they have infrequent symptoms, then they get to a period when they have frequent or severe symptoms. There is effective treatment. This is the other myth in asthma. Some folks, it's interesting what we live with. When we live with what is our normal, I have patients that come to me, I say, how? Because that's what was their normal. So they had since they were, a child or a young adult, and they figure it's normal to them, and they could have pretty bad asthma. So it became, quote, normal to them, right? So they'll say, I'm fine. I'm like, well, no, and then when you get them treated, they go, oh my goodness, oh, I wish I had known this before. I feel so much better, and I could do these things. I just thought I couldn't do these things. So there's effective treatment, and the goal now in 2025 is to get patients well controlled with their asthma. When a person does have a serious asthma exacerbation, because that could be in your health portal, your electronic health record, you'll see this about yourself, and you say that you had a flare. And then you could, when you're, to have effective treatment, we want you to be free of troublesome symptoms through the day and night, and we want you to have almost normal lung functions. Now, there are patients who have asthma that then develop COPD. So there's a group of patients who have asthma who then develop COPD, and we're working on that idea. Some of the new treatments may prevent that. We'll see what the long-term studies show. And the goal is for you to be able to lead an active life, including exercise. That's our goal with asthma. And that should be your goal with asthma too. So here's a normal. So remember I told you, so this is the bronchial, this is the trachea right here, the windpipe right there in your neck. then it divides out right here to these airways called our bronchial tubes, and then it goes into this lung tissue. So this is a normal bronchial tube. See how nice and big and pretty this thing is? Nice circle. You can see through here. You can put something in here. This one is swollen. So this is swollen from this. There's smooth muscle, we call constriction in asthma, where the muscle actually constricts, and that's because of all these nasty this mucus and this inflammation gets released in asthma, and you get this narrowing of the airway, and you actually get some smooth muscle thickening too. And so the wall, you can see that. So you don't have to be a doctor to know that you can't breathe through that thing. So that's correct. So this is why the person with asthma has trouble breathing. So asthma could be mild to severe, like I said, infrequent to frequent. We all heard of people that wheeze. You might have heard people wheezing because it's a common sound, that whistling noise. Asthmatic patients may complain they have chest tightness. They may be coughing because this is the reason. Because if you see that, you can know why. They have airway narrowing. We call that bronchoconstriction. So the flow of the air out of the lungs is low. So they have difficulty breathing out. And they have this air wall thickening. They have increased mucus. So asthmatic patients can cough up mucus. It's this yellow, clear looking stuff. It's not infection necessarily. It can become infectious, but most of the time it's this clear mucus. And we don't like that because that means they're inflamed still. Okay, if they're coughing up that, but that doesn't have to be infection. And that's why it's also important to work with your provider team to understand what your asthma looks like. And if you didn't have mucus before, you need to be calling your doctor for some increase in your treatment. And two, to also know that it's not always an infection. Because the thing will happen with asthma, you go to the urgent care center, a nice, busy, crowded place, with that mucus, they might give you an antibiotic, and then you're still sick because really they didn't treat your asthma. So it's important, right? So your asthma was still untreated, right? So, and then that didn't really treat it. And the new drugs actually might have felt a little bit better because, like, for example, one common drug we use is azithromycin, actually takes away some inflammation. So you can say you probably did feel better because we actually use it in some refractory asthmatic things because it does reduce inflammation, but it's not treat anybody's infection for that reason. So the asthma healthcare team is going to be your primary provider, your doctor, your nurse practitioner, your physician assistant. And then you may or may not need, depending on your severity of your asthma, and depending on your doctor, folks in this community practice different ways, and there's some excellent primary care doctors. They don't need, their patient does not need to see a pulmonologist or an allergist. So it depends, okay? And they can have an excellent, their patients do quite well, so it depends. Every team is a little bit different, okay? So that would depend on your team and your level of comfort. If you're uncomfortable with that, or you just want to just go and say, I just want to make sure, then you should ask that. You advocate for yourself. You say, I need to just go. I want to see the pulmonologist or the allergist, or the ENT doc, Dr. Coker. I want to see them one time or two times. I want to see them once a year. You have the right to have that, and that's your health. You could ask for that. So you may have the pulmonologist, the lung doctor like myself, the otolaryngologist, ENT doctor like Dr. Coker, or an allergist also. And Dr. Coker also does allergy testing as well. So how are we going to diagnose that you have asthma? So first of all, asthma could be very variable in the symptoms. The physical exam of asthmatics who actually not doing well could be quite normal, and the disease is not controlled. Okay, so asthma is quite fascinating. They may be wheezing, they may be not. Some patients are wheezing, they're less less sick than the person who's not wheezing. So it's interesting. So spirometry, patients can have normal lung function tests. We oftentimes have to do what we call a challenge test, or something called a methacholine challenge, to exercise challenge test in asthma. They're, cold, like we could give cold air, just all kind of challenges to get the airway to, let's pretend to wheeze, okay? Then there's this new test, or not, well, in the past 5 years we'll call it new. It's called fractional excretion of nitric oxide. It helps us in asthma management to tell if the asthma is controlled or not. Sometimes in the diagnosis when we're not quite sure. And then oxygen saturation in an asthmatic better be normal. When it's not, we got a serious problem, but it can be abnormal. Okay, so, right, but when it's bad in asthma, you should be in the emergency room. Okay, so labs, allergy testing. Dr. Coker does allergy. It's important. All asthmatics should have allergy testing at one point, at least, once in their life. And then what we're looking for now too, the new is 5 years, right? Blood eosinophils is extremely important. Every asthmatic, we're going to be looking at the blood eosinophils. Remember I told you those are allergy things, inflammation things, because that's going to help us to follow the treatment plan. A chest x-ray, at least one baseline chest x-ray, so your team could know to look, exclude other illnesses. And there's some weird things that happen in asthmatics, some fancy things like something called allergic bronchopulmonary aspergillosis, that fancy fun name. And we might pick that up on the chest x-ray, and we might say, that's why you keep coming back and we can't get you controlled. So there is a reason sometimes to do a chest x-ray in asthma.
Dr. Guy, someone just asked, is it possible to get new onset asthma if you've had COVID?
Yes, it is. So some viruses can set up asthma. So that's fascinating. So the date, the date, the word, somebody's probably looking at that as we speak. So we can't, the evidence points to that, but we can't say that for sure yet, but we could just extrapolate from other viruses. We know that other viral illness probably is what caused asthma. We think that. We know for a fact it can worsen symptoms, but so that's an area of research sort of to know what actually caused asthma. Was it so it's probably multiple things. Like if you the first slide I did in COPD where I said there's environmental exposure mixed with genetic risk. So some folks probably, if you had the genetic risk for asthma and you got a virus like COVID or influenza or RSV or some other virus we didn't know what you had, it might make you then go on to develop full-blown asthma. So that's an area of research, but probably. But for a fact, what we do know is not what we know for a fact is definitely can cause a worsening of known asthma or unknown asthma that you didn't really know you had it. Maybe it was mild, but then you got COVID, like, oh, I got asthma. Maybe you really had it before, but it was mild, so you just didn't, it wasn't diagnosed, if that kind of makes sense. All right. So that goes to quarter the triggers on this next slide, right? So a viral respiratory infection can cause worsening of asthma. And then back to that COVID question. So I had many patients that I saw after COVID, because I still was practicing for a little bit, for a couple of days a week for a while. So for a little, I'm back and forth. I teach a little bit of Temple, but so that's the fun part about being in this retirement period. You had the fun of doing different things. And I love patients, so that's why I did that for a little. I love patients. I miss my patients. So anyway, at post-COVID, post any virus, what I always tell patients, I'm gonna follow you out about, the literature would say, follow a person out 6 weeks. So I'm gonna follow them out 12 weeks and see what happens by that. And then if they still have that after the 12th week, then I'm gonna treat them like they have asthma, like that, okay? And then, but some people after COVID, actually, they get better after about a year. So it's interesting. So, but you should be followed until you have clearance. And if it doesn't clear, you should be continued to be followed, right? So, okay, so worsening symptoms for asthma triggers are the question which is asked, which was an excellent question: viral respiratory infections, COVID-19, influenza, RSV, all kind of viruses can cause worsening of symptoms, right? And colds, right, which are usually some type of they cause worsening of symptoms. Allergens in the air, in our homes, in the work. So we all know about dust mites, pets, and cats are notorious.
Notorious.
So I tell. So sometimes my patients, because their patients who have asthma who are not getting rid of their pet, they love that pet and they not want to go away. So this is where I come down. Dog, some people own dogs or a horse, they're not terrible in asthma. That's the truth. But cats are terrible in asthma. They have a whole disease of their own. But so I have some cat lovers, and we have to have a powwow. If they have severe asthma, we just keep going. I'm thinking, do you like dogs? Can we change to a dog? But because even if you're allergic to a dog, what it does to asthma is totally different. It really is. So allergy is different, but so this whole thing's about what we do with cat allergy. Can be quite severe and even fatal. So cat allergy is quite fascinating in asthma. But anyhow, so pollens can cause cockroach particles, tobacco smoke, exercise, stress. Stress does cause asthma flare. So it's fascinating. A lot of diseases, people say, "Oh, that person crazy." That turns out we're not crazy. Actually, because stress causes, because it sets on a cascade. And so if you get really stressed, your asthma really flares. You could end up in the emergency room. So we have to learn, meditation, relaxation, prayer, all those things to help us to reduce our stress. Because if you do have asthma, that will make your asthma worse when you're having. So you have to learn how to handle that stress so it doesn't hopefully flare your asthma. Then some medications, beta blockers are real common in heart disease. They're common in blood pressure control. And then some patients are allergic to aspirin and non-steroidals like Motrin, ibuprofen. Some people who have those, they can't take aspirin and non-steroidals, okay, because that's the kind of asthma they have. So something that is really important, there's been a change in asthma treatment. This one's very important. So if you have asthma and you don't have in your hand, you don't have to be taking it, but it's not somewhere in your house somewhere, something that has what we call an inhaled corticosteroid. Go back and talk to your doctor about that. This is a new change in asthma. It's a first-line treatment. So you want to discuss this with your healthcare team. And I'm coming to that in a second. You want to have an asthma action plan. So treatment of inflammation. This means not children. I don't take care of children, but this applies to anybody 11 and older and adolescents. So every adolescent and adult patient, medication should include an inhaled corticosteroid. You might have an additional medication in it, okay, depending on your asthma. And you may also be prescribed a pill, which is, because singular, for example, leukotriene receptor antagonist is the fancy term. Ask your team how to use it. It could be maintenance, which is every day. It might be as needed. But the new recommendation This is a big deal because it's every asthmatic should have in their pocket at least an as needed. Even if you have mild asthma, you should have in your house somewhere an as needed inhaled corticosteroid. That's new. Okay, and it's really important because it could be life saving. So the interesting thing is, people who have mild asthma can die. Because so this the tricky thing about not you should tell your loved ones if you have asthma so they know if something's going strange. They could say, oh, maybe they could tell the paramedics maybe it's asthma. They did tell me they had asthma, so asthma's strange. So that's not always the case, but we have mild, and it always is horrible as a pulmonologist when a person had mild asthma, but they end up and they end up dying from there. It's terrible for anybody, but patients, what we have to understand is people with mild asthma can still die from asthma, but we can prevent that. One of the things that prevent that is to have in their hand an inhaled steroid that they can reach for should they need it. So if you have asthma, you go, or somebody that doesn't have it, because this is new. This is hot off the press. Really, this is new. They should go when you do your annual exam. Go talk to your doctor, ask them about that, see what they say to you. Okay, because they could do that. Those things prevent severe exacerbations of flare. They reduce the risk of asthma hospitalization and death. So as I said, even patients with mild asthma can have a severe exacerbation. All right, so that's what we have to understand. So in these inhaled corticosteroids can also reduce symptoms. They can improve lung function. They prevent exercise-induced, remember I showed you that bronchoconstriction where the area was closing off, even in patients with mild asthma. So that's really something important to advocate for yourself and talk to your healthcare team. So there's these other fancy things called a LAMA, which these are add-on things. And then everyone has heard about biologics because the TV keep advertising them over and over. So everybody in the whole country knows about those. Even the little children probably can tell you, recite the commercials. That's something called direct-to-consumer advertising. When I started medicine, they didn't have it. Then it just so it's got pros and cons. The pro is that you go ask your doctor, do I have that? The con is everybody think they should have that. Okay. So do I hear a question?
Oh, you're okay.
I'm sorry.
No question.
Okay, good. So these biologics, these are all over every TV commercial. You hear Dupixent, some other ones for other diseases like rheumatoid arthritis, right? Or they're called biologics. So they're medicines which are made inside living cells and they're designed to target specific parts of our immune system involving a particular disease. So the immune system is involved in asthma is something, something called our eosinophils and our immunoglobulins, E's. These are like allergy kind, and then even some other things, these fancy things called interleukins. They're all these fancy big names. They're part of our immune system. So, and asthmatics is dysregulated, right? So in other diseases like lupus, it's dysregulated other parts, but asthma is like an allergy dysregulation. Allergy is part of your immune system, all right? So Xolair is one of the older drugs.
Yeah.
You may have heard these names: Nucala, Sinclair, Fasenra. Dupixent with the one you hear all over the TV now, right? And your doctor will work with you and determine if you are a candidate. And that's the other thing, if you have a question, you should ask your doctor, because I've had patients who they clearly should have had it, and when they got it, they're like a new person. Everybody doesn't need this because some people control without this. It's add-on. So it should not be first-line treatment ever, 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 okay, period. But it is add-on therapy. And if you need one of these drugs, you should be in the care of an allergist, an otolaryngologist, or a pulmonologist, period. Plain and simple. Okay, you should not, if you need this, this is not okay for just your primary care. No. No, okay. So then your primary care is giving you that. You tell them you need to see, that's where you're gonna advocate for yourself. If somebody needs that, they need to be seeing Dr. Coker, they need to be seeing or a pulmonologist and or a allergist, okay? Period.
Yeah, and even in our practice, the otolaryngologists, we don't use Dupixent, Xolair, Fasenra, but our allergists do. They had to take us out of the equation because they were like, let us manage this.
Yes.
Because it really requires a higher level of specialty.
Yes, it does.
Yep.
Yep, it does, and it requires a lot of hands. So when it first came out, pulmonologists didn't even want to do it. I'll tell you why. So it's interesting. So that, to Dr. Coker's point, the reason pulmonologists do it now, because now we got equipped to do it. The reason why they didn't want to do it at first initially is because their outpatient setting wasn't equipped to do it. Now, let me be clear. When the allergist patients who don't do inpatient medicines, patients got sick, we took care of them when they were hospitalized. So it's tricky business, okay? Yeah. So now fast forward. Pulmonary practice may have, so some pulmonary, it depends where you are. So that's important too. So if it's a small pulmonary practice and they're not equipped, they're going to send you to the allergist. They're going to work with the allergist and the pulmonologist together, right? So it depends, because it's a matter of having the right facilities to be able to do this. But now we have a way where patients can get this treatment themselves. So now the pulmonologist say, okay, we don't have to necessarily inject it. There's treatment now where the patient can take and then we could, inject it home. We could train the patient to inject it home, which makes the pulmonologist go, okay, if it's even a small pulmonary practice. But so you understand, we would take the allergist, and matter of fact, that's where the allergist too also, if you have severe asthma, just putting you in the hospital frequently, you have an allergist alone, you tell the allergist, you're going to still see the allergist, but you need a pulmonologist too.
Yes.
Period. Okay. So, and I've called up many allergists to argue, so not to argue, but to say we're gonna work together because this patient's always in the hospital with the asthma because the allergist don't go to the hospital, right? So the pulmonologist in the hospital in the ICU. So and let me just say this too, if you've ever been in the intensive care unit for your asthma, that's fine to have the allergist, but you also need to see, maybe the allergist is going to see every 3 months, and that's great, but you need to then be seeing the pulmonologist once a year too.
For
so
sure.
be your own advocate, okay? Now, systemic corticosteroids, if we don't have to use them, we don't, but we do sometimes. And often, and the other thing too, asthmatics need to understand, when you have a flare, people who have severe asthma or having a severe flare, they're going to get systemic steroids. I had patients who said not take them because they're not going to gain weight. I said, well, you gain weight, it's a burst of them. And I said, well, but if you don't gain this weight, you're going to be dead. So it's really important that there's reasons for these things. We don't, and we try to taper the person off of them. Okay. Now, the special situation we call comorbidities with asthma. So like I said, some people, if they're in an occupation that either one cause their asthma or exacerbate their asthma. And then there's sheets. If you think you're one of those persons, you can get from your employer. They have those sheets, the MSD sheets that say what's on them, and the doctor can help you see if you have occupational asthma, and they can help you with that. Pregnancy is fascinating. So pregnancy does one of three things to persons that have asthma. It can stay the same. That's like it's a third, a third, a third. It can often stay the same. It can actually get better than another third of persons with pregnancy. And the other thing can just get worse in pregnancy. So pregnant patients were often my patients because their asthma could flare during the pregnancy. And sometimes we had to distinguish, is it just the pregnancy or is this asthma flare? And there's things that's a separate category. And we get patients who are pregnant through the pregnancy well, and we deliver healthy babies, but we needed to be in the hands of their obstetrician along with the pulmonologist. Okay. So then allergic rhinitis, chronic rhinosinusitis. So patients are going to see Dr. Coker for this. If my patients have this and they have asthma, like you have to see, we're going to work together. You got to see Dr. Coker. So, and then because we want to treat their allergic rhinitis and the chronic rhinosinusitis, they flare each other. Okay. So one flares, they flares their asthma, and then the sinus, they flare, so they're going back and forth. So we have to work together. And some of that stuff gets infected too, the sinuses or the bronchial tubes, and then we have to treat all those things. Okay. So then obesity, excess weight, excess weight makes asthma worse. Okay. And when we get patients, that's part of the treatment plan for those who are overweight who have asthma, we know that they can lose about 10% of it. Will have extreme improvement in their asthma control. Gastroesophageal reflux disease, GERD. Sometimes patients are coughing because they have GERD, because they have asthma, because it's what we call cough variant asthma, or they have both. And then we need to treat both things. So sometimes the gastroenterologist becomes part of the treatment team as well. And elderly patients, so this is fascinating too. There's a bimodal, we call bimodal, that fancy statistical term, distribution of asthma. Not only does it peaks two places, one in childhood, but it also peaks in people over 50, which a lot of people, they say, I can't have asthma because I never had asthma and I'm 53, I'm 60 years old. But there's a peak at around 50 for another. It's two peaks. We call it bimodal peaks. A lot of people don't know that. Like, this can't be asthma. I never had this before. So it is a horrible thing to get when if you went through your whole life, then you're 60, but it's okay. We're going to treat you. So please don't say it can't be that because you're that age. There's this peak. There's this bimodal peak in asthma. Then there's what we said, this aspirin exacerbated respiratory disease, which is a special group of patients. They cannot take, this is a whole story. They have to go to the allergist to deal with this. And then there's patients, right, who have food allergy or anaphylaxis. They also have to be seen by the allergist. And, some of those patients have to walk around with epinephrine, make sure they have some severe episode. And then there's a higher risk of severe COVID-related death. Actually, it turned out in COPD, who actually usually as a sicker patient, COVID didn't show that. That patients did bad if they have COPD. It's not good, right? But there was a higher risk of related death actually with this asthma, which was interesting. Even the patient who did not have quite a severe asthma, asthma and COVID-19 don't not get along well. And it's not always in the patient with severe asthma. They don't do well together. That's something very important to remember. So if you have asthma and you have COVID, please take it very serious. And there's treatment for COVID. So if you go, well, my asthma is just that bad, that is it. Unfortunately, we saw patients with asthma who you say, oh my goodness, and some young folks whose asthma wasn't what we thought was, well, we knew it wasn't severe, but they who can die when they get this combination. So that's really something. So take, if you have COVID and you have asthma, take that very serious, please, and call your healthcare providers. Go to the urgent center, the emergency room, to get treatment. Any questions about asthma before we move on to blood clot? Any asthma questions? Okay, so we're going to go on to these blood clots. Okay, so I'm not sure I ever got asked about blood clots in the communities in this setting. So I'm happy. This is exciting to educate, in a lay audience about blood clots. So it's a great question. And so Dr. Coker asked me to talk to you guys about blood clots as well. So we will. So blood clots in the lung or leg, typically what happens is blood clots start in the leg and then they can go to our lungs, okay? So the fancy medical term for a blood clot in our lung is called a pulmonary embolism. You'll hear, and it'll say PE. So a blood clot in our lung stops the flow of blood to an artery or blood vessel in the lung. And like I said, usually comes from what's called a deep venous thrombosis or a blood clot in the leg. And so it embolizes, that's the term pulmonary embolize. It travels to the lung, okay? So here's a fancy CAT scan. I'm going to show you because you'll all be able to see this. And visual learners will see it better than it took me a long time to see it. Whoever's a visual learner, see it right away, okay? So this is the CAT scan again. And we have different windows. So the last ones I showed you with the CBD had the lung windows. These are what we call the blood vessel windows, okay? So this little V, see this like an upside down V? You guys all can see that, right? Right, so this person has got an injection of contrast. So we do what's called a high contrast injection. So when we look for blood clots in the emergency room setting, okay? So they inject the patient with this dye, and then they can see the pulmonary system light up, the arteries, okay? So this V is what we call it's the pulmonary artery, the main pulmonary artery, okay? And this is what we call right here the carina. So you see that? See how that's nice and the blood, it's all white inside of there? So here, looking down in this slide right here, see this gray part right here? That's some gray over here. That's where the blood clot is. So the blood clot stopped the flow of blood. This is a bad clot because this is the main pulmonary. Oftentimes they're out here laterally, but I want you to be able to see because oftentimes they're over here and they're smaller vessels. But this is a great big one. This one can kill patients, okay? Unfortunately. So lung blood clots, the symptoms people present, they're usually suddenly short of breath. They have trouble catching their breath. They often have chest pain. It's typically sharp, but it could be any kind of chest pain, but the classic one is sharp. They may or may not cough up blood. The medical term is hemoptysis, but it's coughing up blood. They might faint. They can faint, what we call syncope. They could be lightheaded, dizzy. They could break out in a great big sweat. They might have a fever. They feel clammy and they turn blue, like their lips and tongue is blue. Their toes and fingers might be blue. And they oftentimes have a swollen leg or swollen lower leg. Because I told you, remember, most of the time, this comes from the leg. It's where most of the time it came from. So how do people end up with a blood clot? So regular healthy people can end up with a blood clot, but oftentimes there's many risk factors. But healthy patients can end up with a blood clot as well, unfortunately. But oftentimes there's many risk factors. So here's the risk. So the risk could be if you have a history of a blood clot or if you're relative. So this is important. So in our community, we're getting way better. So I'm proud of us. So we used to say, we're not going to talk about that, but we're going to talk about it because we need to know our histories. Because it could affect the other ones. So my father is a guy. My married name is Cindy, okay, but I'm not the guy. But that being said, on my father's side, we had a family reunion this summer, actually, and his family's from Derby. So we had it at Bellevue Park. And one of my cousins said, we're going to talk about what's in our family so the young folk know what they, should be preventing or looking for, which was great because my family has something called maturity onset diabetes. But that being said, so you got to know your family history. So we can't no longer say we're not going to talk about it because it could affect, the younger ones in our families. But I was so proud of the guys of my family. We did good. So we had that. Actually, it was the young ones that said we're going to have that. So that was good. So they could know their history. And it was very well received. So we got to know our history. So you have to share. That's why it's important to share your history with your relatives. Not because we're in our business, because this is our business, so that they know, because you haven't had that. So if an older aunt in the family had that, let the younger ones know, because they never had, but that puts them at risk for it, because they're healthy, going, because they are healthy, but that actually is a risk for blood clots. So there's certain things they could do to be preventative, or if they present to the emergency room and they're young, right? So they're fine. There's nothing wrong with them. They have an anxiety. But if they told the doctor in the emergency room, I had two aunts that had a blood clot. The doctor go scratch their head and look, and they're gonna do a CAT scan on them. So if they didn't tell them that history, they're going to send them home because they don't match who the risk factor should be because they're young and healthy. And they're like, okay, it's anxiety is why you had chest pain. So that is very important to make sure that everyone in your family knows the history of their families, right? So another risk factor is prolonged bed rest, like long trips in the car or airplane or train. So when we go, have the luxury of traveling far, if we're going on a long bus ride or like how they stop, you stop for stops. If you're going in the car, you want to get out and stretch your feet.
Yep.
Don't just keep driving because some people just keep driving. Well, I can't do that. I got to stop. But if you got to stop so you can stretch your legs, okay? And then if you're ill, so if someone's ill still, they need to still, that's why in the hospital, so if someone's ill at home, if they can get up, if they're well enough to get up, it'd be nice if they can get up and walk. Say, for example, you just had surgery. That's why the doctor tells you after your surgery, get up and walk around your home, for example, right? Because that prolonged bed rest could put you at risk for those blood clots. Smoking is an increased risk for a blood clot. Excess weight is an increased risk. So oral contraceptive pills, hormone replacement, like for breast cancer, those could be risk factors for blood clots. Pregnancy is a huge risk, and so is the postpartum period. So oftentimes, this is really unfortunate, but that helps too to understand these things. That's why these sessions are good. So if somebody pregnant or just had the baby saying they're short of breath and the chest pain, people have to take it seriously because that's a very risky time. And blood clots are very common in pregnancy and the postpartum, right after pregnancy, right after the baby's delivered. Heart failure is a risk factor for blood clots. Cancer, most types of cancer are risk factors for blood clots. Chemotherapy could put persons at risk for blood clots. And here's an interesting one too. So a personal or family history, don't have to be the person, of breast cancer actually is a risk factor for a blood clot. That's why our family histories are so extremely important, right? So yes, so surgery, especially joint replacement, is a risk factor. Most of the time after joint replacement, the doctor's going to give you a home regimen even for some blood thinners, okay? Blood clotting disorders, and that's why you got to take them. And that's why that's why it's important to understand, make sure you understand when you leave the hospital, tell them and explain these. The nurses are usually very good explaining to the patients, the doctor too, but the nurses they're with you all the time, right? So both should explain, but ask the nurse too to explain because the doctor will leave different things too. And they even we can print, educational materials out now too, to help you to understand. So why they tell you to do all these things after you had surgery, because that's one of the biggest risks for blood clots. So healthy people go and have surgery, they end up and people say they were fine, but the risk factor was surgery, and this could be fatal. Blood clotting disorders, which are, more inherited things, right? Kidney disease is a risk factor. Severe COVID-19 itself is a risk factor for blood clots. So I'm gonna go back to
So while you're searching, Dr. Guy, we had a couple of questions. One was, there's someone taking Xarelto, and they want to know, will that decrease the likelihood of them getting a blood clot?
Yes. So the blood thinners are the treatment for blood. So I was finished. So blood thinners are the treatment. Xarelto is a blood thinner. It's an excellent blood thinner, and it reduces your risk. And so, and then what you want to talk to with your team. Some people need lifelong blood thinners. Some need a time limited period. It can vary. So and that one is about advocating for yourself too. And then ask your doctor. And then sometimes this is really important about advocacy. So this is fascinating. So when we send patients home on the blood thinner, the plan, and so say your primary care looks in the chart, and there is a plan that's given, but the plan, what I find in pulmonary embolism, the plan could be nebulous for the final follow-up care and the length of treatment. So the primary care doctor can look it up and if they don't see it all the time, right, and determine what it could be. But also, in some cases, that person should be coming back to the pulmonologist or the hematologist or the oncologist. So you be an advocate for yourself. Ask them, and ask the primary team, are you supposed to see the pulmonologist? Am I supposed to see the oncologist, who's the cancer doctor? Am I supposed to see a hematologist? Okay, because they might ask you to follow with the hematologist or the pulmonologist. And honestly, if your blood clot in your lung put you in the hospital, it's fair you should have a follow-up care with a pulmonologist or a hematologist.
Absolutely.
That doesn't happen, and that sometimes falls through the crack. I have a pet peeve about that one. So you make sure if you had that you see then the so if they say they can handle, say thank you, that's good. I know you can, because there are excellent primary care providers in our community, so that's good, and they do an excellent job. That's okay. They'll handle it, but you just gonna get your last follow up too with the hematologist and the pulmonologist. That's fair, okay? So for that,
And another question was, if I use an inhaler, is it possible that that steroid inhaler could cause atrial fibrillation?
so no, that steroid inhaler can't cause atrial fibrillation. Other inhalers can cause a cardiac arrhythmia. So some of the inhaled steroid by itself will not cause atrial fibrillation.
Okay.
So some other bronchodilators can cause a rapid heartbeat.
Mm-hmm.
And whether or not we want to say, so we're going to use the word rapid heartbeat. So atrial fibrillation can be controlled or uncontrolled, right? So, and then, so here's a fascinating thing. So I put it like this. So it's complex. That needs to be discussed with your healthcare team because each one's individual. So actually not treating COPD, for example, can cause atrial fibrillation. Okay. So untreated atrial fibrillation, low oxygen is a cause of atrial fibrillation.
Wow.
So that needs a discussion with your individual provider because that's very complicated. And so it could be a circular thing. So not treating it too could give you some, but steroids not going to give you atrial fibrillation, period. But the other bronchodilators in there could be contributory, but then not using them could give you that too. It's very complex. It's a bidirectional matter. So you got to talk to your healthcare team. It's very complex. Mm-hmm.
So, and people that are on long flights, like a lot of people are going to Thailand, some people are going to Australia, some people are going, all over the world. Mm-hmm. So the question is, when they're on these flights, don't you feel like they should get up and walk around on the flights or at least move their legs, just to keep them active? Because I had a friend that went to France. He was a veterinarian, and they all went in to view the facility, and he stayed outside. And when they came out, he was missing. Well, there was an emergency room around the corner, and as it turned out, he had a pulmonary embolus, and he passed away in France. And he wasn't even 50.
Right.
So it can be tragic. Mm-hmm. And our senator, Lisa Blunt Rochester, talks about her husband who had a torn Achilles tendon. And once he had it repaired, he called her and said, I'm waiting on you to get home because I'm having chest pain. Lisa was like, don't wait on me. You need to call 911. And she actually called 911. And by the time they got there, he had passed out. Mm-hmm. And he had a pulmonary embolus.
Right. Yeah. Those are tragic, horrible stories. And and they were in all the risk factors I told you. So, so when we travel, when we travel long distance, everyone, whether you're in that risk factor category or not, because you're in the risk factor category when you make a long distance flight because it was up there, right? So what you have to do is you have to walk around the place. They walk it when you walk around, get up, go to the bed, walk around, come back like that. Walk around, at least once, like walk around, right? If you had a blood clot before, tell the airline attendant so they know. Tell them you're gonna get up every hour and tell them the reason why. Okay, if you didn't have it, do that. But if you did, tell them so they won't, because now they tell you they want to come tell you something. But tell that, and I'm sure they'll be very accommodating if you tell them that. And then you need to put on compression stockings. If you're in that group, if you're in that group of risk factor people with cancer, with congestive heart failure, all those things I showed you, renal failure, kidney disease. You need to have on compression stockings on that long flight and journey. Some persons actually will need a blood thinner. So that's fascinating. So if you had a clot before, and there's different types of clots, right? So you need to talk to your healthcare provider if you're going to have if you're going to take a long trip, you should take it. Talk to your health. If you had a clot in the past, talk to your healthcare provider before you take that long trip, right? That would be a great idea. That's
great. Mm-hmm. Wow, this has been fantastic.
Yes.
Now, does anybody have any other additions or subtractions for Dr. Guy?
Because she have a question.
Let's go.
Okay, I didn't have any of the symptoms of the blood clot. In my lung, I had chest pain, which when they came, the paramedics came, we thought it was my heart. Mm-hmm. So when I got to the hospital, they did a CAT scan with the contrast. Mm-hmm. And both of my lungs they said, significant size clots. Mm-hmm. So, and then while I was there, the nurse tested me for COVID, and boom, I had no symptoms at all. Mm-hmm. But what I want to know, I'm on a blood thinner. I take Eliquis, 5 milligrams twice a day. Mm-hmm. But my question is, does that dissolve? Will the clots dissolve, or will they always be there?
So that's an excellent question. So here's the answer. And then, and you found up with your healthcare team, right? You have a pulmonologist.
I got the pulmonologist. I got the vascular surgeon. I got the primary, and I'm an advocate for myself.
Good. Miss Crumble, I love it. That's exactly what you're supposed to be. So I'm excited. I asked that part first, but then I'm.
And I have a little notebook that I write down what my questions are.
Yes.
So that I won't, because sometimes you might forget, you know, like, oh, I forgot it, but no.
Yeah, so I'm a doctor. So if I visit my doctor, because that's, it's anxiety. People going to something about our own body. You're a doctor, so you got to write them down. Because if you're a doctor, because because it's you, right? And you're like, let me think. You can write them. Yeah, you can put them down. I love your idea. That's excellent. So to answer your question, it's an excellent question. So chest pain that you had was a symptom is one of the major symptoms. Chest pain or shortness of breath are the top 2 symptoms from pulmonary embolism. So you had the symptom, and then they did that CAT scan. You had a significant low, so I'm sure they ended up doing an echo on those things. But anyhow, yes. So the answer to your question is interesting. So the blood thinner that you took does not dissolve the clot. What it does is prevent propagation of the clot, so it doesn't propagate further, right? And you don't get more clot. We do have treatment when people have some high burden. Sometimes we give what's called lytic treatment, like they get TPA or these other things that just go. There's a clot buster. It goes, choop, it busts the clot. And in rare cases, we might have an interventional radiologist, and people are actually like moribund who were like actively dying before our eyes. And they had a radiologist go and try to remove it. But those are people who are really moribund and their right heart's not working, and we think they're getting ready to leave us. And then even sometimes that's not successful, unfortunately. So, and we have in Delaware, though, we do have people that can do that. They don't have people that can do that all over the country, but we actually have folks here in Delaware that can actually do that kind of treatment if need be, and they have saved lives that way. But so, yeah, you sound you're getting great treatment, which is good.
Yes.
You're getting all your answers. I'm glad to hear that. So
yes,
thank you for that comment. That was excellent. Right. Thank you. Hello, Reverend Donegan. How are you, sir? I can't hear you.
Right. So are all minds clear? Because this was a very hot topic. We've got a lot of people that go through a lot of what you're talking about, especially those with post-COVID syndrome. They were doing well, and now every now and then they just feel short of breath. And so we see it every day. And I know, you probably hear it every day, but the good news is Dr. Guy now golfs. He is retired, and you can catch her on the golf course if you need to catch up with her. She's visiting the grandkids, or she's on the golf course. That is where she is. But if all minds are clear, we will turn this over to Reverend Donegan to close us out in prayer. And Dr. Guy, we thank you so much for taking time to speak.
I'm honored to have been invited. I enjoyed it so much. Thank you.
Thank you so much. Dr. Guy, one other question. I know no one asked this, but you look like you have reversed your aging.
Exactly.
And you're trying to figure out what are you taking, because you look wonderful from 20 years ago.
It's called less stress. I think it's called de-stress. But I do. It's called de-stress.
I'm sure you give my regards to Dr. Senioki.
I sure will, sir.
This was a phenomenal presentation. I was listening to all the information you shared with us, and I guess this was almost like a semester's worth of information you gave to us in this last hour. Phenomenal, really helpful, at least for me, and I'm sure most of us on the call will be able to benefit from this. And for those of you who would like to hear this again, or maybe just some specific area, just reach out to Dr. Dennery. We'll make a recording. It's already recorded, but we'll make sure that you can get the recording so you can get some of that information as well as the slides and the presentation. But once again, thank you so much for taking time to share with us. We've been blessed by your presentation.
Oh, for sure.
All right, let's close out in prayer. Gracious Lord, we thank you for the knowledge, for the wisdom, for the understanding, for the skill that you have given to your servant, Dr. Carol Guy. We pray that the information that was shared will in some way enhance the quality of life for those who are able to receive this information and use it. We just ask that you'd continue to keep our bodies, our mind, and our spirits strengthened. Renew us each and every day, that our lives will be used as an example and also to bring glory to your name. We pray that you'll bless us as we depart from this call, but never from your presence. We ask these and all blessings in Jesus' name. Amen.
Amen.
Thank you.
Amen.
Right.
Have a good night.
Good night, everyone. Thank you, Dr. Coker.
Oh, yeah.
Thank you.
A rock star. All right.
Good night, everyone.
Gets it in. So we know you're doing just fine, my dear. Whatever your therapy is, it is working, because we see you on Sunday getting it in.
Yes. Hallelujah. Yes, you.
I have to do it. I don't have no choice.
That's
Make
right.
it do what it do.
What can I do but praise him?
That's right. I
Good
love
night,
it.
everyone.
Good
I
night,
love it.
everyone.
Thank you
Good
for
night.
listening.
Good
Appreciate
night,
it.
all.
Good night.
Night. You can
Night.
unmute. Good night. See how many
Alrighty.
people on the call. Faith.
Yeah, this was great.
Bo.
I was thinking, because tonight was Joy Reid's last night on MSNBC and that whole call to watch the show. But I guess a lot of people recorded it. And I know I did. And then I turned my TV off at 8 o'clock like they asked me to. So, all righty. Thank you, everybody, for hanging in there.
Right.
All right.
Thank you so much.
You got it. Good night.
Good night, one and all.